let's just go up together. All right, we're live, and it's just like that, Mike. It's amazing.
I love it.
Um, Hello, everybody. Welcome back to the JAR Foundation. I say welcome back. Welcome to the second episode of the JAR Foundation. We can't say back because we're hardly anywhere. Um, I really appreciate Mike Fink. You can see here has joined us as a second guest. I just started randomly, not randomly, but very targetedly sending out emails to people of interest. When I looked at their profiles and thought they would add some value in the mental health space. They've got a story. And I got to say, Mike, there's a few when I'm clicking through and I'm like, oh, it'd be good to get this guy or this lady, right, or this person. And I remembered you, partly because your role in the job description, but also because when I did a quick look through, I can see you've been on a lot of the sides of the mental health space, right?
Yeah.
Early on, you've been your retail, you've gone to the tech side. And so it seems that you've really had a journey inside this space trying to solve these problems, and maybe we can't solve them, but trying to help them and address them. So it's great to have you on the show. Thanks so much for agreeing and coming on and spending 30 minutes with us. Let's go through the formula, which is a couple minutes of who you are as a
Sure.
person, as a human. What are you doing today in the space, and then we can talk maybe a little bit about your past, or you can spin it up however you like.
Sure. Well, first of all, Ken, thank you. Thanks for having me. Appreciate it. It's a pleasure to be on here. I always enjoy, in the interest of destigmatization, always enjoy
Yes.
sharing my story, always enjoy sharing my experience, both professionally and my lived experience. So I'm kind of an open book in that manner.
Great.
I probably have less discretion than I should have. Right now I work for Lyra Health. It's a high-flying, wonderful mental health tech company that works with employers, large employer groups,
Okay.
to be part of their employer-sponsored mental health kind of solution, right?
Super.
So
Super.
typically what happens is, you work for, let's say, Coca-Cola, and you call up your health plan and you don't know how to navigate that or find a good quality provider. Some of those providers are no longer in network with, let's say, Aetna. You call around, you don't know what differentiates each provider, things of that nature, right? And before you get care, it's 30 days, 32 days
Yeah.
out, about the
Yes.
average. And so you get attrition. People give up. They give up. They're really depressed or anxious. They call around, they bop around, they never find anybody, or they find someone, they don't develop a good therapeutic rapport, and they have to move on to the next
And
person. And
spin
that is,
back.
it's a daunting process. So it's very disillusioning. So they end up regressing, decompensating, if you will, not getting better, and then ultimately missing work. There's absenteeism. There's lower
Real
productivity.
cost to the company.
There's real cost to the company as far as medical claims. So if they, God forbid, go inpatient because they're, let's say, suicidal at some point or something along those lines, because they're getting untreated, right? So the traditional health plan network is just insufficient, and the traditional way that EAPs have worked historically has just been
Okay.
broken. So Lyra comes in and provides its own network of amazing, hard to reach therapists that are typically out of network with insurances. We basically have a kind of a system or an integration in which we add them on to the health plan, so they're in network and available to
Okay.
employees and their families. That's what I do now. So and I love it. I work more in a partnership capacity, so I get to
Yep.
bring life-changing mental health care to, if I get a contract with a company with 1,000 or 100,000 employees, I get to bring 100, life-changing mental health care to 100,000 people, right? Ostensibly.
Wow. Absolutely. You're literally going to save somebody. Someone in there is going to need
Oh
that
yeah.
phone
No,
call.
there's a very real, we put numbers to it. There are
Yeah.
a number of people in that first fiscal year that are going to reach out because they are suicidal,
Wow.
and we are going to save them. And that you can sure, you can quantify that, but the human piece, the qualification, the qualified piece,
Yeah. You just.
that piece is just so powerful and
Oof.
moving. So before that, though, if you want to know, I was a director of an acute psychiatric inpatient hospital for 5 years. So kind of the front lines.
Wow.
The turnstile medicine a little bit. People come in really, really destitute, a lot of the unhoused or homeless population.
Okay.
And then before that, I was a director of business development at several treatment centers. And then prior to that, I worked on the front lines at some psych wards. And then prior to that, worked with children with autism.
Wow.
And I loved it. I loved all of it. And that doesn't have anything to do with my lived experience, but it was informed a lot by my lived experience. So my wife is a therapist. I can't get away from it. I can't get away. So I love what I do now. I'm
You're
learning.
married to business. You're really married to the business.
I'm literally married to the business.
You're literally married.
That's very well put. So that's kind of what I'm doing now, and I love it. It's different. Again, it's mental health and tech, and it's kind of a lot of noise in that space right now, but
Yeah.
it's fun.
I think, one of the things that I was surprised when I started my research on this was Biden, the White House,
Yep.
President Biden had signed a mental health act, like
Yep.
a basically solve this problem act.
Yeah.
And one of the things on there that really surprised me was bringing mental health education to the workplace. So
Yep.
it seems like you guys, I mean, you're in that role, and I was weird. The thing that got me overseas,
Yeah.
and was my working in corporate. I used to sell insurance to the main corporate, and then employees would buy it on a voluntary basis.
Sure.
A bit like on the early cafeteria plans.
Yeah.
So
Got it.
I was an early cafeteria plan kind of administrator guy and sales guy around insurance. And so when I saw that, I thought, this is just so easy to help people. It's such a stupid, silly idea. It's so simple. It's so smart.
Yeah.
Like literally go to the workplace where everybody is,
Yep.
carve out some time. We do educations or even through Zoom, classes, whatever. So many ways to deliver it.
And that's the beautiful thing is that I think, and Lyra knows this, right? And a lot of the direct to consumer brands like that were doing direct to consumer work, like
Yes,
Talkspace and BetterHelp and things like that, they're going now more enterprise. So they're going business to
absolutely.
business. It, there's a lot of things. Inflation is at play.
Okay.
You have folks that are just unable to pay for out of pocket stuff. But that being said, one way to really scale is to go, you know what? I'm contracted with an employer now that has 50,000 employees. So instead of trying to reach 50,000 Americans
Yeah.
and spray and pray and try your advertising dollars, you contract with one employer and you immediately have access to the employees and their families, right? And so it's one
Yes.
way to really scale your efforts. If you're a solid solution, you're going to do really well. You're going to do really well in that regard, So
Yeah.
yeah, and you're right. They did release guidelines. The World Health Organization and I can't think what else just released guidelines on workforce mental health. So not just looking at mental health as it relates to the members. So let's say, Ken, you are an employee for X company and you're burnt out, stressed, and anxious. You go seek a quality therapist. It's not just about that. It's also looking at systemically the work environment. So is the work environment contributing to your burnout, your stress, your anxiety, depression? So looking at things like role clarity and autonomy at the employee level, and then in equipping managers with mental health literacy and advocacy kind of awareness strategies and tools so they can notice and respond when their employees are struggling with a particular issue, a mental health issue more specifically. So it's
I think it's
looking at
good.
that organizational level wellness and not just at the member level, but at the
Yeah.
population level.
Well, it's even like I'm a big fan of this, which is the kind of the root cause stuff.
Yeah.
Right.
Yeah.
Which is, like you said, role clarity. It could be just a stress the way the job's set up. I mean, look, there is going to be stress at your work. I mean, this is just a fact of life.
Yep.
But if it can be eliminated by training or process or clarity or, simple things by education, then it reduces the stupid stress.
Yeah.
The unnecessary stress, which I'm sure is probably the easy low hanging fruit.
Yeah, exactly. And we can get ahead of it a lot of times, I mean, unmitigated burnout and all that kind of stuff can get compound on itself and really get to a certain place where that person's depressed. And then if that depression is untreated, then that gets to a higher acuity level of depression, and then boom, that person is, a high cost claimant using claims in the health plan for inpatient care because they're really, really, really depressed. And maybe we could have done something at the organizational level to head it off at the pass, right?
Oh, absolutely. They see, I mean, people at work see you every day, 8 hours a day. If you're going to an office or a factory or
Yeah.
somewhere, a school, you're in. So people, I mean, that is a place where you're most likely, somebody could see and that will also where your behavior is going to stand out because it's such a normal backdrop. You've got such a beta line.
Yep.
And when you start falling off that,
Yeah, you're right, Ken. Like we just did the state of the workforce of 2023. We issued it. It's like a kind of like a white paper, if you will.
okay.
And maybe I'm not doing it justice, but part and parcel to that was that employees that were surveyed, we surveyed a ton, said that their managers had more of effect on their mental health than their partners and their therapists. And so, and this is anecdotally.
Oh man, oh
But
that's so brutal.
yeah, there's
Still anecdotal, but still, it's an observation, right?
yeah, it's a certain percent, a significant percentage. 42% said more than their therapist, and another, I forget what the percentage is, said significant. It's because you're right. You're at work 8-9 hours a day, whether you're remote or not. And so your manager has a immense impact on one's mental health, right? So, making sure that manager is equipped with the right work-life balance and those things for him or herself is important because he or she oversees 20, 30, 100 people, whatever the case may be. So it proliferates easily if that person is stressed and under-resourced.
Man, that's why the old adage of, people don't leave companies, they leave bosses.
Exactly.
And it's probably, you could equate that boss with somebody who gives you a really bad state of mental health. You literally leave.
Yep, exactly. And so that's the world I'm in now.
Yeah, really. I mean, fascinating. What are some of the things, what's the most painful thing you see? What's like the stupidest thing the industry does? I mean, is there anything like, what's or one of the things that drives you kind of like you just exasperation?
What drives me a little bonkers, and I say this, and it's going to be a little bit of a polarizing, I'm sure, but I spent a lot of time in the drug and alcohol industry on the treatment side, and I felt like there is a clear delineation between a lot of folks that struggle with addiction and folks that struggle with some more of the mental health sans addiction issues. So let's just say they struggle with OCD or schizophrenia or a mood disorder or thought disorder like schizophrenia, or mood disorder like bipolar, what have you. Now, sometimes you have both, of course, right? But and there are quite a bit of treatment centers out there for drug and alcohol, and they have commandeered or at least marketed themselves in such a way that they treat mental health. And so the underbelly of some of the industry is not too pretty.
I would imagine.
Yeah, in the sense that it's like, well, hey, you know what? Do you have any inkling? Have you used? Have you used? Have you had a sip of beer in the last X, months? And you're like, you know what? That's fine for us. Come on in. And this person might be someone like me who struggles with really high acuity, severe OCD, and I'm not I shouldn't be in an addiction facility, right? So what I've seen is a lot of very agenda driven, very, very, it's about kind of what they call getting heads in beds, not so much about the quality of care and not so much about the appropriateness of the care for for the particular symptom or the particular issue. You get a lot of unsavory bad actors in the space. So as much as like you think mental health is just this, anyone in mental health is doing well by doing good, it's just not the case. You get a lot of folks, particularly in the addiction space sometimes, that I find we're crossing lines that shouldn't be crossed, right? And vice versa. You get everyone's looking to, has a bottom line to some extent, but that was what irked me the most.
Yeah.
It was what irked me the most.
Yeah, and it's I think you end up because you ultimately end up tied to that human, right? You know, it's the person, right? You're watching the system, and the system kind of grinds along like it does, and it's got its ugly parts. But when you see the actual human that's getting, like you said, ends up in the wrong place for the wrong reasons,
Yep. I mean,
it's painful.
it's painful, and that's just, and then they, that's not only time wasted, it's money wasted for the family or the individual. It's they decompensate potentially. And then another area of frustration is managed care can be really frustrating, right? So we used
Yeah,
just
I mean the
just a
whole
little.
just the name is right. Just the name right there is just going to tell you all you need to know.
Exactly. So you used to get enough time in residential to really you would think more time, let's say, in residential level of care, for instance, for a drug and alcohol issue to
Yeah,
heal. Now
yes,
you get 2 weeks, and they want to bop you down to intensive outpatient level of care, which is like 3 days a week for a few hours. And that's just basically
oof,
perpetuating the cycle, because that
yes.
person is not going to get better likely. And
Yeah, it's a lot of time alone after 2 weeks.
yeah, and 2 weeks is insufficient.
It's
If their acuity level is that they need to go to a residential level of care,
yes,
they
yeah,
need to be there for some time, months
yeah,
likely.
months.
And so the individual dropping down to a lower level of care after 2 weeks, and then back into
And then back in,
matriculating back
yeah,
into society, they're going to be right back in that
yeah.
residential
That's I
level of
mean they're
care.
going to cycle back, right?
Yeah, they're gonna cycle back, and it's kind of really sad because it doesn't it's very turnstile.
What do you think? I mean, all this tech that's coming on board. I mean, there's two things, probably two cool things happening in the industry. One is tech, and one is the therapeutics. Meaning, just regular drugs,
Yeah,
the stuff we're making in lab coats, and then the banana stuff. I say
yeah,
bananas just because it's not mainstream.
sure,
The ketamine we talked about. I'm having somebody from ketamine on, which people
yep,
would go, "Whoa!" Like 6 months ago, a year ago, maybe a couple years ago.
yeah.
Mushrooms, psilocybin, and different extracts like that. What do you think? I mean, what do you think the impact's going to be, or what do you see happening with these two? Because you've got the really very traditional doctors who are going to be using certain drugs, right? And there's a proven way to go, right? And we're going to
Yeah,
grind. And then you've got kind of these people kind of coming into the territory to test the establishment and trying a lot of, and it seems new. I know I'm new to this space, but these are like two big changes happening. And even the third one is maybe even, remote and everything digital.
yeah. And when you're saying the traditional players, you're talking about traditional psychopharmacology, right?
Yeah, yeah,
Yeah.
psychopharm. Yeah, I got to get my link,
No,
make
no,
sure
no. I just want to make
it's
sure
good.
we're.
Yeah, that's
Yeah,
something. Because all of a sudden now that there is a challenge to that or an option, right? It depends on how
there's
you
not,
look at it, but there's an option now, and there's becoming more options.
and I think if done, there could always be a bad act,
Yeah, yeah, for sure. There's going to be bad actors. We already
right?
know that.
But I love it, and I tell you why I love it. I love it because we have this brain. It's a big black box. My wife is a therapist, so I have a little bit of the clinician in me, and I'm not a clinician. But I mean, modern psychotherapy has really technically been around for only about 120 years,
Okay.
and since Freud, and so there's a lot we don't know.
Yeah.
And because we don't know a lot, there's a lot that we there's a lot of evidence base for folks with an anxiety disorder, folks with maybe even OCD, but it doesn't encapsulate every individual. There are nuances to every individual that make them them, and that
Yeah.
make them tick. And certainly from a pharmaceutical standpoint, we're we don't have these huge, with some drugs we do, but we don't have with every drug these huge longitudinal studies that show its efficacy for let's say bipolar disorder,
Yeah.
right?
Yeah. Good one. I
So
mean,
a lot of what we're doing is like messing around with cocktails that we know kind of work, some off label, and we're trying to figure out how that's going to best fit this particular individual's,
this person.
yeah, this person. So from a pharmaceutical standpoint, I think you'd be it, it would be remiss for anybody to, for even any psychiatrist to say like, uh, I fully understand how this works. I think and that's maybe what's exciting about the job, but also what that allows for is that opens this space for some
Okay.
of these
Yeah.
newer things like ketamine assisted therapy, psychedelic assisted treatment. And that I think is actually, it's very intriguing. I wish I knew more. I haven't worked for any of those facilities or treatment centers or organizations that are pushing that to the forefront. But I think if we stay iterative, including down to the clinician, the therapist, if they stay iterative and stay on top of things and learn about new trauma therapies and modalities that are coming out and things of that nature, in the same way as an industry, if we stay iterative, I think it behooves us, and it only benefits at the end of the day the patient. So,
Hmm.
I'm all for it. I don't think there's one thing that's a panacea. I think there's a lot of evidence base out there for certain things, but again, each person is an N of one. So isn't any, you know what I mean? Meaning
Yeah. Yeah.
there's sample size of one really, and what may work for 98% of people might not work for the other 2%.
This is strange. It's my second chat, and it's the second time that's come up already
Oh, really?
as a key. Like, just don't forget, just be reminded that every person's different.
Yep.
Like,
Yep.
and just where they're at, their spectrum on the spectrum of, let's say they're bipolar, where they're at on this spectrum, we don't even know how long it is or how wide it is. You're somewhere, each one's on their own little, they've got their
100.
own little sliver.
Yeah.
They own their own little piece of real estate on that. And, it's like, wow. So how do how that is a fun puzzle to solve in a way, because every person you meet's a different challenge and you try to help them. I mean, that could be really addicting in a way.
Yeah, and I like the way you put it. They have their own piece of little real estate on that spectrum. I
Yeah.
love that. It actually feels empowering. So someone with lived mental health experience, and like myself, I go, well, you know what? That actually makes me feel like,
Yeah, you're
yeah, that I'm not just this generic guy that has OCD. That my OCD, it was severe, but it's also unique to me. And there's
for
something
sure.
there's
Yeah.
something very uh, uh, sobering, but also like empowering at the same point.
Yeah,
At the
yeah,
same,
you've got a spot in there. Um, how did you get yours, or when did you get that you had it? How did
so I
that
didn't. Yeah, I didn't. I think the furthest back I can remember it starting, if you will, was around 8 years old. But I didn't get treatment or help for my OCD, and really get diagnosed as having OCD till I was in graduate school, getting my MBA when I was 25, 26 years old. So I suffered for a long time, and it got worse and worse and worse. And I'm sure this is
and
a
you still got through graduate school?
Yeah, I got through graduate school, but I was listening to NPR, and I was some gentleman from McLean Hospital, which is a really prominent, internationally renowned mental health psychiatric facility that treats a number of different uh, issues and conditions. He talked about OCD, and I said, that is exactly what I have. I know that for a fact.
Whoa.
And I had gone through trauma therapy because they didn't know what I had. So I had gone through trauma therapy. I had gone through, versions of talk therapy with different therapists, and nothing was helping. And finally, I was like, that is exactly what I have. So I reached out to that individual on NPR, and that doctor, and he connected me with someone in San Diego County where I was living at the
Okay.
time.
Okay.
And it wasn't, by the way, that started the long road that I've been on, but it saved my life. It saved my life. Right. So I suffered a lot. I was playing highly competitive ice hockey up until college and into college, but I quit because I was having such horrible panic attacks and obsessions and compulsions related to my OCD, obviously. So it was affecting, and then unmitigated, unabated, if you will, my OCD and my experience. And this is what I find is
Right. Yeah.
kind of a through line with others is if untreated, it gets worse, unfortunately. So if you're not doing anything about it, and so as I didn't do anything about it from 16 to 17 to 20 to 25, it would get worse and worse and worse and worse and worse. So,
You're not going to grow out of it.
no,
Yeah.
there
And I
is,
think it's important to say that, because there's people suck it up.
yeah,
He'll be fine. He'll be fine.
yeah. I mean, there is some really cool, interesting, a book I read about, you kind of age out of some of the I forget what it's called, but you can age out of some stuff
There's
to
some
a
stuff,
degree.
right? Yeah.
To a degree, you kind of like age out of, and this is a book around addiction, but certainly with a chronic mental illness like OCD, not saying that addiction is not, but a chronic mental illness like OCD, you don't age out. You don't, once the switch is kind of turned on, in my experience, and I've run support groups, I've helped
Yes. Okay.
place people, I've helped coach people. The switch doesn't turn off unless you really get at it, So, first is the insight, and I didn't have the insight for years.
Yeah, that had
So
to be life. I mean, that had to be sitting down with a therapist the first time, and they start going, you feel like this? Do you feel like this? And
yeah,
and you're just going, oh my God, it's me.
how fascinating, this is fascinating too, a statistic is that it's about 14 years from the time for any mental health issue. The average is about 14 years from the point at which they start exhibiting symptoms to the point at which they get help. So yeah,
Whoa.
because they don't know what's going on,
Yes. Yeah.
the appropriate help, I should say. So for me, an OCD, it's actually 17 years, and that actually held true because I was 25, so that was 5, 6, 7,
Yeah.
8,
Yeah.
8 years old. So it was actually like I was like, wow, it like hit it on the dot. Now it doesn't matter if it's 5 years or 17 years. It's terrible either way. But yeah, for on average for a mental health issue, from the time at which said individual starts exhibiting symptoms to the time at which that individual gets the appropriate help they need, doesn't matter what the mental health issue across the board, it's an average of 14 years of a wait time.
God.
It speaks to the access issues that we have in the industry and the quality of care issues, which is
And not
something,
and knowledge,
and knowledge,
education, right?
stigma.
Uh,
Yeah,
and
stigma.
and also that those two are kind of combined, aren't they?
They are.
They are. There's some crossover. The other thing that was in the or I don't know, maybe if we talked about it, but the paper, the White House paper, was integrating your actual health,
Yep.
your medical health,
Yep.
in with a mental health benefit, and
Yep.
kind of forcing those, which you kind of described, before earlier, saying that road you go on. But
Yeah.
yes, forcing that to happen at the retail level, in the hospital, in the clinic, at your HMO, at your PPO,
Yep.
that you have access, not this
Yeah.
banana where you can't get a doctor.
Yeah, I mean, the parity was a huge deal for a long time, and then they kind of, I think there was a legislation in around 2010 that, if I'm not mistaken,
Okay.
that established parity. But yes, it's about and now they're looking at value-based care. But yes, it's about being able to, um, you know, yes, kind of
Yeah.
bundle those together where and when appropriate. There's obviously a comorbid effect. If you don't, untreated mental illness can really affect your physical health, right? So it's,
I,
there's
I,
really some great organizations that are doing some great work, Lyra included, but with partnering with other organizations that do more primary care, and so that they integrate their services so that when someone has goes and gets their blood pressure checked,
mhm.
they also are screened for anxiety, what have you, and then shuttled appropriately to Alira or whoever it might be. So integrating those two pieces is paramount, because a lot of times your primary care practitioner is responsible for prescribing the meds that you're on.
Oh yeah, yeah. Interesting.
Yeah, so it's
It
getting
would
that.
change the role for the primary care, right? Because they're now going to be the point of your physical health and your mental health,
It
and
is, yeah.
managing everybody behind them.
Yeah, and some of this is above my pay grade, but yeah, I mean, I just know that it behooves a primary care practitioner, I think, and it certainly makes for the patient it better.
Yes.
It betters the care if that person has a little bit of a pulse on the mental health piece, and so can at least kind of notice and respond accordingly when said patient comes into their waiting room, or comes
Hmm.
into their room rather, and they're demonstrating signs of X, Y, depression, anxiety, what have you. So it's a great starting point, and you see a lot. The more we can integrate the physical piece, and the mental health piece, and those two verticals, if you will, the better.
It's going to be fascinating to watch that. I've got some thoughts on that as well. Even, how that managed care now becomes a real, and
Hmm.
this is really becomes a managed care.
Yeah.
Interesting, changes that role. I wonder if somebody like Alira, maybe it becomes more of a platform that doctors plug into,
Yep.
and
Yeah.
that platform follows me as an individual no matter where I go.
Exactly.
And
So
Lyra manages that, and the doctors can go in and coordinate on the platform, on my personal health platform.
yeah, so we're doing that as we speak. Actually, we just launched a partnership with Accolade, which is a care navigation
Oh
service.
yeah, yeah, I know them.
Yeah, and they do some really great primary care work. And so the details of what that partnership are far and wide, and I can go into that. But yeah, that is kind of a part and parcel to what we're talking about right now.
All right.
So we're in the mix, right? So value-based care, integrating the medical and mental health piece,
Okay.
all of that is a step or steps in the right direction to create a more seamless process for people that access care more quickly. And then obviously the quality of care is also what matters as well on the other end.
Yeah, absolutely. And I think we'll get better at being able to measure that. Hell, if Amazon can get 10 million reviews, why can't we get reviews on Doctor? Like, I mean, review it, right? If we can review some poor little Shenzhen guy manufacturing cable parts to charge your phone, can't we get a review on my doctor online?
Sure. It's an
You know what I
interesting
mean?
it's something that's an interesting thought experiment, because how do you review a doctor that or a therapist or a psychologist, and when you have folks that some are mentally still sick or ill, and so, you know what I mean. So
Yes,
the reviews
absolutely.
the reviews might not be too too good.
Fascinating. They would be fascinating to see,
Yeah,
though.
yeah. I mean, if you look at any reviews for a inpatient psychiatric hospital like the one
Yeah,
I was,
you've seen this.
yeah, the reviews are pretty bad. So I mean, not to laugh, but I
I
mean,
know, no,
you
just
have
the
to
yeah.
have some comic relief, right?
Come
So
on,
it's
this is so serious. It's such
yeah,
heavy stuff.
yeah, it's heavy stuff.
It's
So
heavy stuff.
it's hard to really encapsulate it. These aren't widgets; these are humans. And on the flip side, therapists and doctors and even treatment centers by extension, they're humans. It's all about it's the treatment. It's the treatment that matters, and that is a very nuanced, not always just a cookie cutter thing to evaluate, right? So
Mm.
it's interesting. Good thought
Every,
experiment, though.
everybody's got their slice of real estate on the spectrum.
Right, right.
Everybody's got their own little DNA spot. Um, Mike, we hit the time. We're even a little bit over. I'm gonna try to manage my time, so it's like I'm like at 30 minutes exactly.
No
But
worries.
it was such a great chat. I didn't want to end it. Um, Total selfishness. I'm thinking it's awkward to ask me or to ask you to give some bit of advice for the audience or something, because that's bananas. Maybe there's not even anybody listening, and maybe nobody will ever watch it. Who knows? But at least I've had an amazing conversation.
I have to.
um, how about advice for me? Just total selfishness. I'm on this journey. We kind of chatted before. If you were me building, trying to build out this nonprofit, and to do
Yeah,
it, with decent resources, and I'll find some money eventually.
yeah.
Um, any advice for me on this, where I'm at on this part of the journey, and then we'll wrap it up.
So I think that's wonderful that you asked that. I think people are hesitant to sometimes ask because they think it's selfish or what have you. I think it's very
Mm,
it's self-serving, but in the most humble, beautiful way, because I think the work you're doing can be very, very impactful. Stay open, stay optimistic. I think are two things that I would say.
okay.
I think the psychoeducation piece is absolutely huge, and like I kind of mentioned,
Love
we
it.
talked
Love
about
it.
earlier, is part and parcel to the destigmatization piece. The more we learn and
Yeah.
understand mental health, the more it gets destigmatized. So keep doing what you're doing. You
I
don't need to
like
be a
that.
clinician to do what you're doing. You don't
Yep.
need to start a mental health tech company to affect the mental health space in a large way. And I think it's all about connections. Just like we say, what heals a lot of people that are suffering from mental health illness is connecting, really truly connecting with other people, heart to heart,
Yes.
from an interpersonal standpoint. Connections in the same way are going to behoove you so well. So leverage me, leverage my network,
Yeah.
leverage the next gentleman or female or someone that you interview, leverage them and their network, and just let it kind of declare itself, but keep doing what you're doing.
Thanks, Mike, so much. Really appreciate that. That's like powerful advice for me, and hits home a lot. Again, thanks so much for being a guest. We'll drop off the live, and I'll see you in the other room. I'll see you in the green room. Thanks, everybody, for supporting the JAR here, the JAR Foundation, and then also my JAR podcast, my regular gig, where I do go face-to-face and sit down with people and talk about real human topics face-to-face for an hour plus. Great show if you're not watching. And look forward to seeing somebody tomorrow. I've got another guest tomorrow, and then somebody on Thursday. I'll see everybody. Thanks.